Good morning. We have a special treat today. Many of you in the room know Dr. Turnage, and to show that things move on, many of you don't know Dr. Turnage. He left here in 2008 and has been at Arkansas since. He went there as their chair of surgery and ascendancy through about 10 different ranks. He's ended up as CEO of the UAMS health system and Senior Vice Chancellor of Clinical Programs there. I don't know where he plans to go from there, but I guess the Peter Principle hadn't happened to him yet. He's still on the way up. His history dates back, though, when he graduated from medical school from right here where you guys are in school. 1983. Were y'all born yet?
I know, it's pathetic, isn't it?
Why do we invite these old guys?
Why do you ask those questions?
I don't know. But he started out, graduated medical school right here. He grew up in Shreveport, Bossier. His family's still here. And he got here last night and hadn't seen his mother yet. But I bet he's talked to her. When he left here, he went to the University of Michigan, where he did a surgery residency. And he apparently did pretty well because they kept him on his faculty at the University of Michigan. But he got a better job, wanted to come back south, and so he came to the University of Texas Southwestern. And he worked there a while until he got a better job, which means he came here from there as chair of the Department of Surgery, where he stayed for 7 years until he got a better job. And that's when he went to Arkansas. So we're blessed to have Dr. Turnage with us today as the professor who's visiting, thanks to Dr. Eggerstadt, who invited him to be the AOA professor this year. So he has in store for us a lecture. I'm going to turn this off because your mic is here.
Oh, okay, fine. Can you hear me okay? Oh, great. Dean, thank you for inviting me to come and talk in Grand Rounds today. And Jane, thank you so much for inviting me as a AOA visiting professor. It's one of the best honors of my career, and I really am owe you a debt of gratitude. You know, when I was a medical student and as a resident, what I was interested in was kind of the facts of taking care of patients, and I hated lectures that were on something that was softer than portal vein thrombosis or Budd-Chiari or some other kind of clinical entity. But as I've gotten older, these things have become more important, and I can see why some of the visiting professors that came to Michigan when I was training there, and even here as a resident or as a student talked about some of these things. And what I'd like to talk about today is transparency, but in particular public reporting in healthcare, because it's a big deal, and whether you know about this or not, it's going to certainly you're going to be caught up in this, whether you're a surgeon, an internist, or whatever. And I've got basically 4 goals in this talk, and to talk a little bit about what transparency is and the ethics of it. We'll talk about, and I'll show you some of the sources of publicly reported healthcare information that you can get to right now. We'll talk a little bit about the history of this as well. We'll talk about how patients, families, and healthcare providers use this information. And then lastly, I'd like to show you a little bit about of some of our experience at UAMS in public reporting of patient experience data. So I think this definition is probably as good as any having to do with transparency, and this is by the editor of the New England Journal of Medicine, and his definition is: transparency is providing patients with information and involving them as full partners in decision making. Don Berwick was the head of CMS early in Obama's tenure, he was one of the people that implemented Obamacare, and he's been a part of this transformation in healthcare that we've been going through for the past 10 years, and been a leader in this. And he talks about 5 transforming concepts of how an organization, a healthcare organization, becomes safe, effective, and highly reliable. And the first of these 5 is transparency in everything that we do. The Institute for Patient and Family-Centered Care, transparency is 2 of the 4 principal concepts of it. Patients and families will receive complete and honest information, and patients and families participate in their care and decision-making up to the level that they choose. Being transparent is part of the tenets of professionalism that underpin the medical profession, and in particular, the principle of patient autonomy. That is, the patient gets to make decisions based on their own beliefs and what they feel is in their own best personal interest. And it's part of our responsibility of honesty to them. These principles and these responsibilities come from the Physician Charter, which was produced in 2002 by the American Board of Internal Medicine. It's since been endorsed by more than 130 organizations. The American College of Surgeons' principles and responsibilities are nearly identical. When you think about transparency, it can occur on a level of a single individual talking to a patient, like this is Laura Hutchins is one of our busiest medical oncologists, talking with one of her patients and fully informing them of all of their options. It can also occur at the level of an organization themselves, presenting data and presenting their results to the community. And then lastly, and what we'll spend a fair amount of time talking about is kind of third-party organizations collecting data. It's like investigative reporting, collecting data and then pushing it out to the public. To me, those are 3 kind of examples of transparency and public reporting that there are right now available online and in Barnes & Noble and a variety of other settings. Public reporting of outcomes started in the 1700s, and it was Florence Nightingale actually driving the British Army to improve the conditions within the hospitals in the Crimean War. That was really the first time health or hospital data was reported in the press and had an effect on the care that was delivered. This is Ernest Amory Codman. He was a principal founder of the American College of Surgeons. It was his work that also founded the Joint Commission. But in the early part of the 20th century, he was concerned about physicians, surgeons, hospitals not following their patients, keeping track of the outcomes for their patients, and then reporting that publicly. One of his ideas was the end result idea, in which is the common sense notion that every hospital should follow every patient it treats long enough to determine whether or not the treatment has been successful, and then to inquire, if not, why not, with a view to preventing similar failures in the future. It was his work that founded M&M Conference, That is now a part of every, it's a mandatory part of every training program in the United States. So between 1917 and 1986, from the perspective of public reporting, not much happened. But in 1986, and some of the professors in the room will remember this, and many of you were, many of the students and residents weren't born yet. But in 1986, was the first publishing of hospital results. And this was published by the predecessor of CMS, and they published in books the outcomes of hospitals in treating people with pneumonia, with myocardial infarctions, as well as with that had undergone a CABG. And this is a report from the New York Times. More than twice as many patients died at certain hospitals than would have been expected under normal conditions. The administrator for HCFA, which was the predecessor of CMS, said this is not meant to be not meant to point an accusing finger. It's not a report card on the nation's hospitals. It looked a lot like a report card on the nation's hospitals. So you can imagine there was a ton of criticism of this. And Jack Owens, the Executive Vice President of the American Hospital Association, said it's the dumbest thing I've seen HHS do. A counsel for another hospital group said it's utter folly. On the other hand, the head of the Public Citizens Health Research Group and other patient advocacy groups said, we've been waiting for this for a long time. And the head of AARP, it's better to err on the side of providing more information to consumers than less. So that was 1986. Within a couple of years, papers started coming out looking at the results of this, and in particular with CABGs. And what they saw was, this is one of the papers published in JAMA in 1994, and it looked at the outcomes, at mortality rate from patients undergoing coronary artery bypass grafting from 1989 to 1992. And what they saw was a 41% reduction in mortality rates between 1989 and 1992. And the conclusion of this was, this is the result of public reporting, and we need to do this more. By the way, Hannon is he was the administrator for the Department of Health in the state of New York, which was one of the early adopters of this. And as you look through he was the only MD on this paper. You look through the rest of the people on the paper, it was MPHs and other kinds of things. But I've taken that first paper in blue, in the bars in blue, and superimposed the results of a second paper that was published from Massachusetts a year or so later, a couple of years later, and looked at the same time period. And what you see is in Massachusetts, they didn't publicly report. They didn't produce this document. And what you see is the same 41% reduction in mortality rate associated with CABGs during that period of time. And so as you think back, and as the authors thought about this, there was an improvement, that they felt that the reduction in mortality rates associated with that operation, which was also being seen across the country in other studies as well, was really due to better cardiac anesthesia, advances in cardioplegia, advances in the care of patients with myocardial infarction and congestive heart failure. It was due to those things rather than due to the public reporting and improved outcomes. Well, over the next 20, 25 years, there have been a ton of places where that publish outcomes information from hospitals, from doctors, from nursing homes, from dialysis centers, from all kinds of different healthcare providers. And this is just a couple. I'm going to walk through a couple of these to show you what they look like. And probably the most widely known or most widely used is this from CMS. And this is hospitalcompare.gov. And you can go to this website. And the whole point, as the editors of this website say, that the point of this is to allow an individual to compare, to understand the results of a hospital, compare one hospital to another, and incite people to ask questions, patients and their families to ask questions when they go to a hospital. And so this is, when you type in hospitalcompare.gov, this is what you come to. And you can pick up or type in the name of a hospital or the name of a community. It'll list all the hospitals. And so I typed in Willis-Knighton, and here's Willis-Knighton's information. And so it shows some general information here, and then an overall rating on 1 to 5 stars, and we'll talk a little bit about this in a minute. But then information about, it shows the survey of patient experiences, the results of timely and effective care, complications, readmissions and deaths, imaging, and then payment. And so if you click on patient experiences, you're drawn to a table. And what you can see is that it compares Willis-Knighton with Willis-Knighton's results with other hospitals in Louisiana and other hospitals in the nation. And this is a survey. It's a standard HCAHPS type survey, which is basically a patient experience survey. And it asks questions like patients who reported that their nurses always communicated well. And so you can see at Willis-Knighton, that's about 78%. The average for Louisiana is 84. The national average is 80. Doctors that always communicated well. Willis-Knighton's about 83. Louisiana average is 88. National average is 82. And you can, it goes down to other things. Pain was always well controlled, et cetera, et cetera. So how about timely and effective care? Well, you press that and you come to a kind of a menu of some basic procedures and basic things in medicine. And so if you can find out information about their cataract surgeries, colonoscopy follow-up, heart attack care. If you press heart attack care, again, it takes you to a table like this, again, comparing Willis-Knighton, Louisiana, national averages. And so the average number, the median number of minutes for outpatients who come in complaining of chest pain before they get an EKG. You can see Willis-Knighton's 11 minutes, national average is 7, Louisiana average is 10. And then patients with chest pain who get an aspirin within 24 hours, you can see it's 99% for Willis-Knighton, and you can see what the averages are. You know, think about, so this is me and you looking at this, and I'll tell you this, for each of those tabs, and then in each folder underneath it are charts or tables like this. And you know, the way I try to think about things is how my mom would be able to interpret this. And there's a ton of data, and it reminds me of this. It reminded me of this Far Side cartoon. Mr. Osborne, may I be excused? My brain is full, because there's so much information presented in this. And really, for the average person, and you talk to Terry Davis, and she tells you that 50 to 60% of our people in our community are kind of reading at a 5th grade level. I just don't know how useful those tables are going to be to those people, and really drawing down and being able to make a choice based on that information. So the star rating system was started this past summer, and it enraged physicians and hospital groups around the country. And what CMS was trying to do was provide. It's no different than looking at a restaurant, looking at the star rating on Yelp of a restaurant or a TripAdvisor. It's a way to easily judge quality and non-quality. And as you look through the critics of this, everybody agrees that having some kind of a measure of hospital quality is a laudable objective. CMS's goal, as I said, was to help patients and families learn about hospital quality, compare facilities side by side, and ask important questions. There were 64 quality measures grouped in 7 domains, but the weighting of those and how they came up with that was really based on those 4 items: mortality, safety of care, readmission rate, patient experience. As you think, and as you dig deeper into this, and the things that irritated so many editors and hospitals was that folks weren't shown the methodology before it was printed. So you basically learned last July your hospital star rating, and it's been updated quarterly. It's based on data that's 4 years earlier. It's based on CMS data or on administrative data and data that we ourselves deliver to them. There's equal weighting of metrics that have dissimilar clinical significance. So, for example, let's see. Mortality is rated the same as patient experience, having to do with adequate pain relief or whether the bathroom is clean. There's also heavy weighting on measures that statistically just don't hold up and are not valid. And one of these is a composite measure. There's a lack of risk adjustment for things that just affect outcomes. The comorbidities of patients, the socioeconomic background of patients, and then lastly, for those hospitals that don't show or don't have enough data in any of these categories, the way that the data was treated was that if there was insufficient data in a category, say mortality, but they had really good patient experience, they took the patient experience data and just put that in the place of the mortality data. And so what ended up happening was that specialty hospitals, small hospitals, were favorably represented in the star ratings. University hospitals, safety net hospitals were pushed in the other direction. So this is a website from an investigative journalism group called ProPublica, and this was launched in 2015. And what you see as you visit the introduction to the website, everyday surgeons with the highest complication rates are performing operations in hospitals nationwide. With this new information, patients will be able to weigh surgeons' past performance as they make what could be life and death decisions. Doctors themselves can see where they stand relative to their peers. There's another website called surgeonratings.com, does the same basic kind of stuff. If you go to the website, and this is what this is a screenshot taken just a couple of days ago, and this is what the kind of stuff that's on it. And so they're looking at everything from landlords in New York City to Agent Orange to the Trump administration. As you go into investigations and ultimately work down through it, you come to surgeon scorecard. And so you can, by entering a diagnosis, you can find surgeons in your community that do that procedure, or you can enter a particular surgeon's name. And so in this case, I entered an orthopedist up in Little Rock. And what you see, in the way the data is presented, he does a bunch of, his practice is purely hip and knee replacement. So you can see that as long as they've been monitoring this, done 758 knee replacements, 413 hip replacements. He's had 15 complications. Raw complication rate is 2%. This is where he fits relative to his peers. You can see they've tried to generate some standard error bars or confidence intervals. These are the other, each tick in this is a different surgeon. And you can click on each one of these little bars and a surgeon's name will come up and you can kind of look into that individual's results. Same thing with hip and knee replacement. But as you start to dig into this, the data comes from an administrative data set. It comes from a Medicare inpatient data set that was published from 2009, or it had patients from 2009 to 2013. The calculated death rate and calculated complication rate is adjusted, but the methodology is proprietary, and so no one's able to inspect it as you would in a peer-reviewed publication, like in a journal. But they say that they adjust for differences in patient health, age, and hospital quality. And they're excluding emergency operations, outpatient procedures. Interestingly, with outpatient procedures, one of the procedures that they look at is lap choles. And so as you know, almost all of them are done as outpatient procedures. So the ones that wouldn't be done would be the very most complicated patients. And so it would push those results, again, negatively. Again, this has been, this website has been criticized, and some of the criticism associated with this, John Birkmeyer is a surgeon who is also a epidemiologist, and he noted they used administrative data to measure the one component of quality for which administrative data has been shown to be the most flawed. And Justin Dimmick, who works with him at Michigan, there's too few surgeries for any given surgeon to generate statistically meaningful results, resulting in wide and overlapping confidence intervals. And then Mark Friedberg said, with confidence intervals like these, who needs enemies? And then lastly, and I think most importantly, the real danger of scorecards like this lies not in their failure to capture quality, but in their pretense that they've succeeded. And then lastly, I'd like to show you and talk a little bit about Yelp. Yelp has 100 million reviews online. 6% of them have to do with healthcare. So 6 million reviews of physicians, clinics, hospitals, health facilities. This is UAMS's. So in their STAR system, and who knows how they came up with this, but in their STAR system, we have a 3 stars. Actually, what it is it comes from individual ratings, just like you would a pizza place. Has a couple of pictures that I don't know what this picture is, but it looks like pictures that patients have taken and then posted online, and then is you're able to write a review. And so this is an example of one of the reviews that we got. And it just to briefly say, our second was born at UAMS, and since then we've used them every time we need hospital services. They helped us, or they let us beta test a system called Angel Eyes that allows people to watch their baby when it's in the NICU. And they talked about Deborah, one of the nurses. She made us feel like she had love for him too, not just a duty to care for him, etc. So this is a totally different kind of content than the surgeonsratings.com or hospitalcompare.gov. You know, this is like, I don't know, being at Brookshire's and you meet up with a friend that as you're shopping. This is a conversation, and it doesn't have the data, but it has important experiences. And the thing that's important in this is just how many people this gets to, and the whole concept of 100 million reviews is just, with 6 million of them being associated with healthcare, is mind-boggling. And at the very least, it's important for us to understand this source of information, to realize that this is feedback from our patients about experiences that they had through their eyes. We can't ignore this. Just like a restaurant can't ignore their online reviews, we can't ignore our reviews because it's what people are saying about us. So the notion it has been that by publicly reporting outcomes, you'll improve healthcare. You'll improve the quality of healthcare. And that you would do so by guiding patients to select high-quality healthcare providers, whether that's a hospital or a doctor. Also by stimulating healthcare providers to improve their own processes of care, and then aiding purchasers, whether that is the government or insurance companies or hospitals themselves, actually, to identify and contract with high-quality providers. So it's providing information, and the thought is that people would use that information to make decisions about who they're going to go see, that a hospital might use that information about which doctors they're actually going to bring onto their medical staff. So so we already showed data that really suggested that publicly reporting outcome data doesn't improve healthcare results. And since those studies in the early 90s, there have been no data to suggest that that it does. And it's been looked at a variety of times, but there's no data to suggest that publicly reporting outcomes like hospitalcompare.gov that it fundamentally improves hospital results. So how are people using this? So this is a paper that was published in the early 2000s that asked the question. It was a survey of 500 patients that had undergone a major operation, a major elective operation. And they asked the question, how important was surgeon reputation, hospital reputation, prior care, hospital comparative data in your decision about where to have surgery? And so as you can see, the two most important factors had to do with the reputation of the surgeon and the reputation of the hospital. About 80% of people said that those were the most important factors. Prior care, about 40%. Outcomes data, the published outcomes data, was about 10%. I'll tell you, earlier data, the data that was published in the 90s about from the CABG databases, less than 1% of people use that information to make decisions. So this is actually starting to get into at least into the double digits. This is a study that was published in 2014 and in JAMA, and again it was interested in whether people used information online to make decisions about healthcare. And they surveyed 2,137 people. It was, they did it in a way that was representative of the population of the United States. And they asked these questions. Are you aware there are websites that rate and review doctors, hospitals, restaurants, cars? You can see that about 65% of people were aware that there are websites that review physicians, 61 hospitals. If so, have you used these websites? 87 cars. If so, have you used these websites within the past year? Actually, a little more than a third of the people had used those websites to review physicians. And about a fifth reviewed them to evaluate hospitals. And by and large, they found them to be important. The information was valuable. And then, again, in this same study, it looked at the importance of these various factors in selecting a primary care physician. And so the question was, when selecting a primary care doctor for yourself, how important is each of these in the following? Well, they looked, again, experience was more than 90% of people said that that was very important or somewhat important. And word of mouth, about 85%. Referral from another physician, about 80%. But online now came to about 60%. And so again, this is the first time that people are actually using online reports to shop for a doctor or a hospital. And it's fundamentally different than it had been certainly 10 years ago. This business about about part of a trusted group, physicians' years of experience, that reputation part, to me that gets to Yelp, because it's people talking about their experiences and affecting the reputation of that organization. Well, what's the effect of public reporting on the individual physician? And in particular, would it cause physicians to pass on doing complex or procedures on complex patients, on medically ill patients? Because you need to keep your score up, so you're going to let that person pass. And that person with congestive heart failure. So this is a study that looked at rates of percutaneous coronary intervention, so PCI, and it compared the rates of patients undergoing a PCI in reporting states in blue, and you can see that those are New York, Massachusetts, and Pennsylvania, versus non-reporting states in red. And there were 20,000 patients in these various groups. So even a relatively small number was statistically significant. And you can see that in each of these, in all patients, the rate of PCI was higher in non-reporting than in reporting states. People that had a ST elevation MI, again, it was higher in non-reporting. People that were in shock when they underwent it, and people that were older also, the rate was higher in states that report or didn't report than it was in report. Here's what it looked like over time, comparing Massachusetts, which reported, to all the other states that didn't. And you can see an inflection point at the year they started publicly reporting their PCI outcomes, and that rate went down. So it suggested, at least from these cardiologists, that they were beginning to pick patients according to how severely ill they were. And it's been looked, that same question's been asked about patients undergoing a CABG, and that data is, some studies suggest that the cardiac surgeons actually will select patients, but most of it shows that they won't. How do hospitals view this data? And so this is the results of a survey of hospital CEOs, and 380 CEOs and other hospital leaders were asked about how hospitalcompare.gov affects the hospital's reputation. And in particular, do they agree that it affects the hospital's reputation on mortality, readmissions, process measures, and patient experience? And you can see that most, well, almost all, about 80%, felt that this publicly reported information it affects the reputation of the hospital, and that certainly is how I view it. And then also, does it stimulate your hospital, your organization, to do performance improvement activities? And again, you can see about 80% of the hospitals said yes. It identified an area of concern, and it stimulated these activities. Now again, nobody's ever demonstrated that it's resulted in improvements in mortality or reduction in readmissions or any of those kinds of measures, but it sure stimulates folks to pursue things that might. So I want to show you lastly some things that we're doing at UAMS in publicly reporting our patient experience data. And the way that this came about was, I don't know about you guys, but our patient experience data was just terrible. And we were routinely in the 10th percentile, 25th percentile, and over years. And we talked about it and talked about it and talked about it, and it never seemed to improve. And so one of the physicians on our faculty, we had heard a talk about a couple of hospitals around the country that were publicly reporting their own information, their own data, in particular their own data about patient experience. And so we started talking about that, and we thought it was the right thing to do, and within 6 months we did. We thought it was the right thing to do from the standpoint of if we've got this information, we probably need to show patients from the standpoint of honesty. We also thought, if we're showing individuals, patient satisfaction, the information, that it might get our physicians and folks to pay more attention to it and hence improve our results. We also thought that it could provide a market advantage to us with other hospitals in the state. And then lastly, if you Google a physician or you Google a hospital, the first thing that comes up, at least with a physician, is health grades. First thing that comes up with a hospital is Yelp. And so we thought that we could put this in place so that the first thing that came up was actually our rating system. And that's actually the way it's worked out. So what it looks like is this, and where it's published is on our Find a Doc website. And so you go to uamshealth.com, and you'll have an area where you can type in a doctor's name or a specialty, and it'll come up with the doctors. And again, Laura Hutchins is an oncologist that works with us, and so you can see there's some basic information about her, her specialty, diseases that she treats, and then we talk about our patient ratings. And these are in various areas, like she explained things clearly, she listened carefully, easy to understand instructions, showed respect, and then the overall rating. It calculates an overall score for her of 1 to 5 stars. You can see hers is a 4.9 out of 5. And then we published verbatim every comment that a patient says, unless they use cuss words or something like that. But everything else is published verbatim. Every month, so this changes every month. Every month we push out to them kind of a report card, this information online. This is what it looks like from your handheld device. And again, it shows her current rating was 4.88. She's 27th out of 100, or almost 200 people. And then this is how it looks in each of those categories. So what we found, and we've been doing this now for 2 years, and what we found was that the average STAR score was 4.75. And this fits with what's in the literature and what other people's experience is, and that is people, by and large, really like their doctor, and they're going to rate them high, by and large. And you can see that, I don't know, 90% or so are get 5 stars. I'll read a report that talks about one bad experience, couldn't find a parking place, food was awful, waited forever, and then the doctor gets 5 stars. And it really is, because by and large, folks, they love their doctor. So this data is a little old. We had 17,000 reviews. Now we're over 20,000 reviews. We have about 300 of our physicians are reviewed. You have to have 30 different reviews before it's posted. You can see that the average score is 4.75, and then we allow a mechanism for people, if they want to contest the publishing of these comments, they can contest it. But it's contested to me and to the dean and to a couple of other people, and of the 68 that were contested, we ended up publishing 50. And the notion is that we want to try to ensure the people that are looking at this, that we're not editing these things, that we're just pushing it back, that we're being frank and honest. So we pushed this program out over a period of 6 months, which is I can tell you that's the fastest anything has ever happened at UAMS. And initially the physicians were fairly resistant, as you can imagine, but it actually has grown to kind of be a part of what we do. Here's a couple of comments that came from our physicians and are reasonably representative. I was apprehensive about this whole physician transparency initiative, but when I read my patient's comments that I did not wash my hands before I examined her, I knew I had to change the way I practiced, and now I have. The other day, I had 2 patients tell me they chose to see me because they read other patient comments about me on our website and liked what they read. So I know my patients are doing their homework. And then lastly, thanks. I will work harder to improve. I will spend more time to listen and give patients more opportunity to ask questions. You know, the way I see this, I mean, it's pretty potent stuff because your mom's reading this. So she's going to look up your website and she's going to read these comments. You know, you're going to want to pay attention to that. So in summary, we talked about the definition of transparency, and it's providing patients with information, involving them as full partners in decision making. That the ethical basis of this is patient autonomy and our responsibility to honesty. We went over a couple of the sites of publicly reported, or sources of publicly reported healthcare information: hospitalcompare.gov, ProPublica, Surgeon Ratings, Yelp. And then lastly, this is a review from the Agency for Healthcare Research and Quality, which is certainly a proponent of publicly reporting. And it kind of lays out the current status of publicly reporting healthcare information. And what it says is that the heterogeneity of outcomes and the moderate strength of evidence for most of these outcomes make it difficult to draw definite conclusions about whether it impacts the quality of health care. And I can just tell you there's no studies whatsoever that show that it really impacts the quality of health care. But Public reporting is more likely to be associated with changes in healthcare provider behaviors than it is the behaviors of our patients. Quality measures that are publicly reported improve over time. Frankly, most of our measures improve over time, but certainly if they're publicly reported, they tend to. And then they mention that the amount of research on the harm that it does, so for example, physicians choosing to avoid more complex patients is limited. It is limited, but there's probably a half a dozen papers, most of which show that there is some moving away from taking care of people that are more complex. The way that I see it is summed up in this quote, again from JAMA, and I see this publicly reporting of outcomes data as a problem of implementation rather than a problem of theory. And this is certainly not going to go away. It is something that we have to pay attention to and something we have to be involved in. And so for us to do this ourselves makes a heck of a lot more sense than a group like a consumer. It's Consumer Checkbook is the group that does surgeonratings.gov, or ProPublica does the other surgeon rating system. We need to do that ourselves. We can do it through the American College of Surgeons. We can do it through our own organizations. But to push this information out, I think makes good sense. Cleveland Clinic does it with outcomes as well as with patient satisfaction information. And then lastly, I'll go back to Codman. And this is a cartoon that he drew. And what you see is this ostrich, and he calls it the Back Bay Golden Goose Ostrich. And Back Bay is a community in Boston. And the ostrich is laying golden eggs and kicking that gold to the university, actually, to the faculty of the university and to the hospitals. And what he says, what he thinks the ostrich is saying to himself, if I only dared look and see, I might find a doctor who could cure my own ills. This is the Board of Trustees of Mass General, and what they're saying, if we let her, the Back Bay Golden Goose Ostrich, if we let her know the truth about our patients, do you suppose she would still be willing to lay? And then lastly, I think, I don't know who this guy is, but it said, I wonder if clinical truth is incompatible with medical science. Could my clinical professors make a living without humbug? Humbug is deception. And what he was trying to push the Board of Trustees at the Mass General to do was they finally started actually collecting data. He was trying to get it publicly reported. During that 10-year period, he was kicked off he was on the faculty, kicked off the faculty, and finally accepted back onto the faculty. But this was published actually as he was a member of the faculty. Well, I am delighted to have been invited to come back and visit with my friends and to give this talk. I'll be happy to answer any questions.
We have a couple of minutes. Dr. Ghazi-Zabari.
Dr. Turnage, I enjoyed your talk. I think it's very timely. As you know, our field of transplantation was been under scrutiny for quite some time.
Right.
I look at our outcome data and seeing that, comparing our center to Ochsner, they allow them to have more like one year survival of kidney allograft was about 88%, but it's expected of me to be 91.5. So when I look into it to see why patient population is the same, we live in the same state, if anything, is actually ours are sicker patients.
Right.
Because they were not dealing with Medicaid at all.
Right.
And then I realized that the reason they had that break because they entered all comorbid conditions with their patient. Diabetes, hypertension, coronary artery disease, obesity, we did not.
Right.
And as soon as we entered our comorbid condition, suddenly our expected outcome came down to about mid-87, 86. So,
Right.
So for residents and students, I think it's very important when you're doing cholecystectomy or hernia repair, an 8-year-old man with obesity, diabetes, hypertension versus an 18-year-old kid, you're trying to fix the hernia, complication and comorbid conditions clearly would have a positive impact on it.
It's crucial in this public reporting. It's crucial in, that information is what populates that hospitalcompare.gov website, and it's that same information that determines in this new macro environment where physicians, there's much as a 20% swing in pay for physicians that's coming on board by 2020 is determined on capturing all of those comorbid conditions. And that's part of the problem with the data. And then, and how do you, it's hard for us to understand. I just can't, my mom can't possibly, is not going to be able to understand that. Almost none of our moms are. I think I'm okay. And so what we've got to do is present the data in a way that they can understand. And we've done a lot with health literacy in our clinics, but we've got to pay attention to that also in how we interface with the public.
Dr. Chu.
Yeah, Dr. Turnage, that's a wonderful talk, very provocative. For the residents and medical students who don't know it, Dr. Turnage actually recruited me. He was my academic mentor. So by extension, he is your academic grandfather.
That's comforting.
Should we use against him? So here's the question. It looks like we're moving towards on a granular level, which is the surgeon's level, and now there's a very controversial group of people who are saying now we're not looking just at the hospital and surgeons, but also limiting the surgeon's scope of practice, looking at exactly how many Whipples have you done, how many esophagectomies have you done, and then and basically telling surgeons that you cannot do these without being monitored or being reviewed. So I was just wondering your thoughts on that, and it looks like we're getting to a part where surgeons are now tearing each other apart, trying to, in many ways, game the system. So I just wonder what your thoughts were.
The people in this room can hear you, but the Conway.
Oh, I'm sorry. Okay. I think what you say is right, and I've seen change. I've seen it kind of change in our own credential. What you're talking about is through credentialing,
Yeah.
and I've seen it change in our own credentialing committee, and I've been on that committee for almost the whole time I was at UAMS, and I stepped down when I became the CEO, but I saw that same kind of, it's kind of activism, and I tell you, I don't know what's necessarily right, and the reason that I say that, the way I had always thought of this was the way that I was trained to think was that you learn bits and pieces of operations, and so if you think about a Whipple is there's many pieces to that. Part of it is a gastroenterostomy. Part of that is a pancreatic resection, and part of it is a hepatogenostomy or cholecystectomy. And so you learn those in individual pieces that you put together to do a Whipple. But I tell you what these committees are looking at are also looking at the very real thing of is it safe to have a surgeon do 5 carotid endarterectomies in a year, and is that the right thing for us to be doing? When you've got another surgeon that does 5 a week, and so I think what our job to do is is just to take the high road and think about what's in the patient's best interest and not the physician's own best interest. I mean, that again gets to the physician charter. The very first thing in the principles is the privacy of patient welfare. And I've always thought that if you just do what's in the best interest of the patient, the rest of this stuff will take care of itself. But it's and there is plenty of opportunity for people for one surgeon or one group to cast stones at another, but you've got to be careful because we all live in glass houses. So that's how I see it. It's the same with public reporting. Part of the issue with Yelp is anybody you can write a result, and so even a person that doesn't get health care that's angry at you from something you did in church. So they're getting online talking about how you messed up their gallbladders. So I think we just have to kind of be pure of heart and do the right thing. That's how I see it.
Well, we've gone over, but we didn't want to miss this opportunity.
One resident.
Which one? Connor.
Sorry. I was just going to thank you very much for the talk.
I don't care how long you talk.
Thank you for the talk, and thanks for that last comment. It's amazing to hear surgeons now talking about how patient interest and is much more important than their money or their personal interest of doing surgery. That's an awesome time we live in. I was going to make a comment on how y'all started at UAMS doing the patient reporting,
right,
and how you talked about how those are the things that patients find most important in selecting their surgeon or hospital is, other reviews or people's reputation. But you also alluded to how some things are more important than patient experience, how, mortality and those kind of things are more important. And will y'all plan on doing, outcome stuff on your website as well? And then the question is, how do you do that without getting people confused with statistics? Because you can't just say things like all-cause mortality and expect, people at a 5th grade reading level to understand what you're talking about.
Right. Thanks for those questions. What we're doing now, and so we started thinking about adverse events in our hospital differently. And so instead of reporting those rates, we report them as people. And so I know in our hospital we have about one person every day is injured by an adverse event, whether it's a needle stick or whether it's an employee needle stick or whether it's a UTI or something like that. And actually what we're going to start doing is publishing that on a computer or on a video monitor just like that on every patient ward. And so we're rolling that out to where on every ward, when you walk right by the nursing station, at the nursing station is going to be a monitor, and that monitor is going to have a little bit of, like half the screen is going to be, wash your hands, that kind of stuff. The other half is going to be some results that are specific to that ward. And it's kind of, I mean, it's kind of like a construction site. It's been 8 days since we've had a UTI. It's been, our hand washing rate is 80%. I tell you, our hospital, maybe your hospital, the hand washing rate ought to be pretty simple. Ours is like 50 to 60%. That's what it is kind of nationally. It's just terrible. That guy that talked about that, I mean, it's just the way it is. So we've got to improve that. We have an issue with C. diff directly related to hand washing. So we've and that's how we're going to do that. We'll also publish them online, but that's how we do it.
Anybody else? Don't let me make another mistake. Okay, Richard, thank you so much for coming, and let's all go to work.
Thank you.